So good afternoon, good evening, or good morning, depending on when and from where you're joining us. I'm Dr. John Iskander, and it's my pleasure to welcome you to CDC Public Health Grand Rounds for February 2018. We have an exciting session for you, so let's go ahead and get started. Public Health Grand Rounds has continuing education credits available for physicians, nurses, pharmacists, veterinarians, health educators, and others. Please see the Public Health Grand Rounds website for more details. Grand Rounds is available on all of your favorite web and social media sites. Please send comments or questions to the Grand Rounds email box, grandrounds@cdc.gov. We also have a featured video segment on YouTube and our website called Beyond the Data, which is posted after the session. This month's segment features my interview with Dr. Janet Wright, Executive Director for the Million Hearts Program. We've also partnered with the CDC Public Health Library to feature scientific articles about the Million Hearts Program, and the full listing is available at cdc.gov/scienceclips. In addition to our outstanding speakers, Dr. Janet Wright, Leslie Meehan, Dr. George Schrader, and Dr. Kathleen Tong, I'd like to acknowledge the important contributions of the individuals listed here, in particular the efforts of Hillary Wall in spearheading this session. And I'd now like to introduce CDC's Acting Director, Admiral Ann Schuckett, for a few words.
Well, thanks so much, John, and thank you all for participating today. Like many of our Grand Rounds, today's topic is personal. My mother's father, uncle, and brother all died from heart attacks in their 50s. But thanks to stopping smoking, high blood pressure control, and cholesterol maintenance, my mom is still complaining about my hairstyle at age 89. I visited the cardiologist with her last week, and he says she's going to be doing it for a while. Cardiovascular disease, heart disease, and stroke is still the leading cause of death in the United States. It kills more than 800,000 Americans each year. It's too common, it's too costly, and too few people do the simple things they can do to prevent it. After 40 years of steady decline in heart disease and stroke death rates, that decline is decelerating and even flattening among certain groups of people. For example, we see troubling increases in deaths among adults aged 35 to 64. Cardiovascular disease rates are also higher among African Americans. The southeastern United States is so hard hit that we often refer to this area as the stroke belt. Even with these challenges, we know that we can improve health for people with cardiovascular disease when health systems, communities, and individuals come together. The Million Hearts Initiative is co-led by the CDC and the Centers for Medicare and Medicaid Services and embraces other federal agencies and 120 official partners. The first 5-year initiative began in 2012. Using evidence-based public health and clinical goals and strategies, Million Hearts has so far saved at least 100,000 lives. One of those lives saved may have been someone you know, a friend, a family member, and very likely some of us here today. Over the next 5 years, Million Hearts will redouble its efforts to engage and equip partners and stakeholders nationwide to reach the goal of preventing 1 million cardiovascular events by 2022. Million Hearts 2022 focuses on keeping people healthy, optimizing care, and improving outcomes for priority populations. Today, with this wonderful group of speakers, you will hear federal and state perspectives on keeping hearts healthy, as well as examples of the outstanding prevention work being done by both primary care and specialty physicians. Million Hearts continues to meet milestones toward our goal of preventing 1 million heart attacks and strokes by 2022. I want to be at that party. It will not be easy, but with hard work and collaboration with partners like these and many others, we can save even more lives. Thank you.
Thank you very much, Dr. Schuckett. Our first speaker is Dr. Janet Wright.
Thank you so much, John and Dr. Schuckett. And on behalf of the entire Million Hearts team, and especially Dr. Betsy Thompson, the new Division Director of Heart Disease and Stroke Prevention, Judy Hannon, the Senior Advisor of Million Hearts here at CDC, and especially Hillary Wall and Brianna Lucido, who made today possible for us. We are all grateful to the CDC Grand Rounds team, Drs. Iskander and Thorpe, and also Alicia May. I'm particularly grateful to you all for coming, for sharing with us your wisdom and your road rash, and showing us all how we can help more people get and stay healthy. These are the facts that you know. We know that cardiovascular disease is common, it's lethal, it's costly, and it's a major cause of differences in life expectancy across races and ethnicities. What you also likely know is that cardiovascular disease is largely preventable when individuals and communities and health systems work together to improve cardiovascular health and care. What you need to know now is that after 40 years, as Dr. Schuckett mentioned, after 40 years of steady decline in both heart disease and stroke death rates, that decline is indeed decelerating, flattening. The slowing in the rate of decline most likely reflects the triple whammy impact of diabetes, decades of diabetes and physical inactivity and obesity conspiring to cause heart attacks and strokes across age groups and across the country. As shown on this frankly frightening slide. This slide shows the data that Dr. Schuckett referred to. It shows county-level percent change in heart disease death rates among a combined 35 to 64-year-old age group. The red indicates an increase in heart disease death rate, while the gray indicates a decrease. Alarmingly, cardiovascular disease mortality is rising in these younger people from Maine to California. And as many of you know, the first phase of Million Hearts was riding atop this beast of a burden from 2012 to 2016. And with the leadership and the contributions of over 120 public and private sector partners and many others, this collective effort made headway despite the headwind. Many accomplishments will bear returns well down the road, like the 9 million fewer smokers and the artificial trans fat policy that, when fully implemented, is predicted to prevent thousands of heart attacks and related deaths each year. But change is hard and progress is slow. Because not all the targets we set were met, we will likely fall short of 1 million events prevented when the final data are available in 2019. Our partners, though, taught, they learned, and they shared very valuable lessons in this first phase of work. First of all, a catchy aim intrigues and inspires, and it happens quickly, so you better be ready to tell people what to do. Public health and healthcare rowing their very unique boats toward the same destination just makes sense. We learned that less is more, choosing a few high-impact strategies and measures and offering flexibility in implementation is one secret to progress, if not immediate success. We know that those who are deeply invested energize everyone and they make progress possible. We learned early on to connect and convene through websites, listening sessions, webinars, and particularly social media. We learned to keep the signal strong by anticipating the inevitable changes in the world of science. And then finally, we learned to seek and celebrate those positive deviants, those who are doing extraordinary work, and try to lift them up. An example here in the room is Dr. Schrader's work. So armed with this wisdom, we use the results of fresh modeling exercises to select priorities, those high-value, high-impact actions that will lead to 1 million fewer events over 5 years. As you see here, the contributors, the heavy hitters, are the B, the C, and the S. There are a few caveats about this slide. The first to know is that the aspirin data here relate only to its use for secondary prevention. We anticipate a number of events prevented from increased use of aspirin for primary prevention. Sodium exerts its influence through blood pressure control, and cardiac rehab has a substantial impact on reducing the chances of a second event in those who've already had one. The contributions of increased physical activity are substantial, but they are expressed over a lifetime. So let's get moving, not during this grand rounds, but shortly thereafter. So based on these results and guidance from experts, and many of whom are in this room or joining us online today, and input from public and private partners, in January of last year, we launched the next 5-year phase that we call Million Hearts 2022. We're starting afresh with an event count of 0 and aiming to prevent 1 million events by December 31st of 2021 under the continued co-leadership of CDC and CMS and executed by a variety of local, state, and federal partners. Million Hearts 2022 rests on a tripod of priorities. As Dr. Schuchat mentioned, those are keeping people healthy, optimizing care, and improving outcomes for priority populations. The goals in each priority were chosen for their impact on outcomes. The first, you see here, keeping people healthy, rests on community-based policies and practices that make it easier for people to get and be healthy at work, at play, and at home. We are thrilled to add physical activity to Million Hearts 2022 and grateful for the guidance from experts here at CDC and from partners across the country. Second, optimizing care. It's designed to help ensure that those with and at risk for cardiovascular disease receive the care and treatments known to help them avoid a heart attack, a stroke, heart failure, kidney disease, and even dementia. By achieving at least 80% performance on the ABCS, that's aspirin when appropriate, blood pressure control, cholesterol management, and smoking cessation. By improving cardiac rehab participation rates to at least 70% of those eligible, an important addition that you'll hear more about from Dr. Tong today. And finally, helping clinicians engage their patients in heart-healthy behaviors, such as self-monitoring of blood pressure and participation in the diabetes prevention program. And third, improving outcomes for priority populations. These 4 subsets of the population were chosen for an intense focus based on 3 criteria. First, significant disparity in outcomes. Second, effective or promising interventions to help address that disparity. And third, well-positioned partners with whom to work. Here are the Keeping People Healthy strategies selected to help move the needle by 20% over the remaining 4 years. Local food purchasing policies can enhance consumer choice for lower sodium foods while encouraging more producers to offer those lower sodium alternatives. Smoke-free spaces and higher tobacco prices are effective in driving down tobacco use. And promising evidence shows that increasing access to places for physical activity and designing communities and streets with activity in mind and peer support groups can help individuals get and stay physically active. Under optimizing care, evidence and experience show us that when widely and systematically implemented, these strategies achieve big results. Technology such as algorithms to identify and address gaps in care, patient portals, electronic and default referrals and registries, teams including pharmacists, nurses, community health workers, and cardiac rehab professionals, all working in concert at the top of their abilities. Processes that ensure quality care and reduce non-clinical variation, tools like treatment protocols, daily huddles of the medical team equipped with current performance on the ABCS, and proactive outreach to patients, finding those with undiagnosed hypertension, high cholesterol, tobacco use, and those who would benefit from referral to DPP or cardiac rehab. And then finally, patient and family supports, problem solving around the issues of medication adherence, counseling on nutrition and activity and cessation, and avoiding exposure to air pollutants, and systematic referrals to community-based physical activity and cardiac rehab programs. Million Hearts is focusing extra attention and action on a few subsets of the population with a particularly high burden of cardiovascular disease. These are African Americans and Blacks with hypertension because of a lower control rate in that population, 35 to 64-year-olds in whom we see event rates rising, those who've already had a heart attack and stroke because of their very high risk of a recurrent event, and individuals with mental illness or substance use disorder who are also using tobacco. We hope that you will join us in addressing the needs of these groups or apply similar criteria to identify your own priority populations, and that you will share your progress and successes with us. It's now time to turn from theory to practice. Today, we're going to showcase the exciting work underway across the country that is already contributing to progress in these new areas of Million Hearts. Clinical and public health actions that are increasing physical activity, improving risk factor control in high-burden populations, and using cardiac rehabilitation to help those who've already had an event live a healthy and event-free future. While listening to these experts today, think about the roles that you can play, the actions you can take, and what part of the solution you can be. Our first speaker today is Leslie Meehan from the Department of Health in the great state of Tennessee. Leslie.
Thank you, and it's a pleasure to be here with you today. This afternoon, I will be presenting our work in Tennessee to use the built environment to increase physical activity and decrease chronic disease. Tennessee's solutions illustrate involvement from various sectors and levels of government and emphasize how to frame public health in a way that resonates with decision makers. We know that healthcare is vitally important, but that most of our health is influenced by our environments and the choices made in those environments. While not de-emphasizing healthcare, community-based primary prevention focused on our environments and choices must be the foundation for population health change. Tennessee's primary prevention built environment strategies align with the Active People, Healthy Nation and Million Hearts 2022 goals of increasing physical activity and keeping people healthy. Most chronic diseases and conditions are a normal response by normal people to an abnormal environment. Let's think about the physical activity and nutrition environments that are driving patients to battle chronic disease and seek health care. This is the abnormal environment, and we must work with other sectors to undo the decisions that created this environment. When we talk about the built environment, this picture is what we mean. We all have this street in our community. Would this be the picture that we would put on our hometown postcard? It certainly lacks opportunities for healthy eating, walking, and bicycling. Everything in this picture, the signs, the width of the street, the types of businesses, is a result of policy that is either absent or present. These conditions contribute to decreased physical activity, poor air quality, reduced access to affordable and healthy foods, reduced personal and transportation safety. The lack of transportation options are also a barrier to accessing healthcare, since 1/3 of the nation's population does not drive. Streets like that contribute to trends like this. The green line is the increasing numbers of miles we drive each year as a nation, and the blue line is the increasing adult obesity rate since the 1960s. I previously worked as a transportation planner for the Nashville Area Metropolitan Planning Organization, responsible for nearly $8 billion in federal transportation funding. With guidance from CDC experts beginning a decade ago, the Nashville region became one of the first regions in the nation to think about how we were spending funding and what the health implications of transportation might be. Several years ago, I joined the Tennessee Department of Health to start the Office of Primary Prevention with a core focus to increase physical activity through the built environment. Of the top 10 leading causes of death in Tennessee, all can be positively impacted by an increase in physical activity, particularly through publicly accessible opportunities for walking, bicycling, and play. Setting the stage for this work is the integration of primary prevention as a central tenet of the Tennessee Department of Health. 95% of our over 2,000 county and regional employees for the past 5 years have been engaged in community-level primary prevention efforts, providing all staff, nurses, office staff, dietitians, dentists, the opportunity to get outside the public health walls, return public health to the community, and contribute to prevention through safe routes to school programs, walking trails with tobacco cessation signage, breastfeeding pods, and over 2,700 other initiatives. In 2017, we updated our state health plan to a primary prevention framework, and all 95 counties in Tennessee have created primary prevention plans, acting as strategic plans for community-based primary prevention work, including physical activity opportunities through the built environment. To measure our progress, we created the Tennessee Vital Signs. Notice the circled areas. We are measuring the work of other sectors, since education, income, and physical activity opportunities have been shown to be large influencers of population health outcomes. The vital signs don't just belong to the Department of Health, but to our state. Since we know that health is driven by local environments, in June of 2017, we hired 7 healthy development coordinators located in each of our 7 regions. The job of these coordinators is to think about access to healthy foods and physical activity as communities grow. We received more than 400 applications from over 30 states for these 7 positions. Next, we utilize state funding to create the Access to Health through Healthy Active Built Environment grants. There are 2 grant types. Something for Everyone, where all rural counties, 89 of the 95 in Tennessee, receive $10,000 for convening, planning, programming, construction, or evaluation around increasing physical activity through the built environment. The second is a competitive grant, up to $85,000 for the same types of activities. This year, we have $1.8 million to award and received more than $8 million in requests for this money from 71 of our 95 counties. Greenways, parks, playgrounds, and walking tracks are the types of physical activity promoting facilities recommended by the Community Preventive Services Task Force. We know that public health and healthcare alone cannot solve chronic disease, and that many decisions made by our sister public sector agencies are having implications that we, as public health, are trying to mitigate. Therefore, in 2016, the Tennessee Livability Collaborative was created to improve the prosperity, quality of life, and health of Tennesseans through collaboration, a health in all policies approach to state government with 12 state departments at the table. We are currently developing a protocol to collect physical activity information as a vital sign for the 1 million plus patients we see annually. We utilize programs such as Healthy Park, Healthy Person, developed with our state parks department to prescribe exercise medicine in parks across Tennessee. There are many opportunities for health and transportation to work together. One is data collection. The Middle Tennessee Transportation and Health Study involved the Nashville Area MPO, the Tennessee Department of Health, the CDC, and the U.S. Department of Transportation. Over 11,000 participants answered transportation questions as well as 6 health questions: height, weight, average time spent in physical activity for transportation or leisure, average time spent sitting, self-assessment of diet, and a self-assessment of overall quality of health. The $1.5 million study was paid for with funding from the U.S. Department of Transportation, included CDC guidance, and provided a wealth of information around the intersection of transportation, land use, and health. From the transportation and health study, the Nashville area MPO then looked for common attributes of households that reported lower quality health. These attributes included at least 3 of the following: poverty, unemployment, lack of a car, and household members over age 65. Using this information, the MPO was then able to target investments for sidewalks, greenways, and other active transportation amenities, providing opportunities for physical activity and transportation, and representing many millions of dollars in investments. Finally, we can model the impacts of our decisions. The Integrated Transportation and Health Impact Model creates scenarios for population-level increases in walking, bicycling, and transit, and forecasts the resulting health impacts. One scenario included an additional 10 minutes of daily walking or bicycling across the Nashville region, so about a half mile total, and 23 fewer miles per week of driving per person. The model estimates reduced cardiovascular disease at a population level by 3%, reduced diabetes by 3%, among other health improvements tied to physical activity. $116 million a year is estimated to be saved in healthcare spending, savings that is on par with how much the MPO spends annually on transportation infrastructure. Models like this help public health illustrate the potential impacts of transportation decisions. This work was done in partnership with CDC and supports the types of strategies and thinking promoted by Million Hearts. In closing, Susan Ortega, Chief Nurse of the U.S. Public Health Service, calls on her colleagues to go into uncomfortable places and be nimble engineers. I challenge all of us to collaborate with other sectors as we bring multifaceted solutions to address chronic disease, promote physical activity, and healthy eating. Thank you again for the opportunity to be here with you today.
Thank you, Kathy. I have the privilege to present our approach to the ABCs of heart health, aspirin use, blood pressure control, and cholesterol control, and the promotion of smoking cessation. Depicted here are the specific Million Hearts clinical quality measures for the ABCs of heart health. They are included in numerous quality payment initiatives. Later, I will show you how our practice addresses each of these. Plymouth Family Physicians has been an independent family medicine clinic for the past 33 years in Wisconsin. We have created an 11-member team whose focus is quality. Our performance numbers are a measure of the value we offer our community. We are grateful to have participated in our region's Healthy Hearts in the Heartland study, allowing us to contribute to answering the question, is quality performance possible in a small practice? As part of Healthy Hearts in the Heartland, a QI facilitator made monthly visits to our practice, providing structure and assistance to our quality improvement efforts. Our path to improving our performance, however, began 20 years ago with our decision to remain an independent practice. Ownership allows us to pursue quality to our heart's content. In 1998, we purchased an EMR with an affiliated practice-based research network. We joined that research network, PPRNet, and began participating in its studies. Those multiple PPRNet studies set most of our ongoing QI priorities, including blood pressure management. In the process of administering these studies, PPRNet refined its data management skills. Now, apart from ongoing research, PPRNet continues to provide us our monthly performance data on an actionable format. In addition, its nationwide network of members are our closest colleagues. PPRNet presents us with the science of medicine, then measures our performance. It is our job to bring the two together. If you value something, measure it. When you get the data, trust it. You are never doing as well as you think you are, and just resolving to work harder won't affect improvement. You've been working hard all along. We were at this very juncture of needing more hours in our day when we realized the help we were looking for was already in our practice. We recognized that our patients give our employees authority beyond their education. We took advantage of this and actively involved all of our staff in the quality performance process. Every one of them today will say that this involvement has made their job more fulfilling. Personal interaction can drive change, so every patient staff encounter becomes an opportunity to advocate the science of medicine rather than to discuss the weather. In our practice, everyone is a provider. Medical assistants are not trained for this role. The training must happen in our practice. Every week we have a 90-minute noon meeting that covers policies and the problems of the day, but also the science behind our performance goals. We review our QI data and strategize on improvement. At quarterly half-day meetings, we go over the complete set of data. When we are part of studies such as Healthy Hearts in the Heartland, we gather the entire group for the visiting educator's presentation. During all of these meetings, we close the office, focus on the science of medicine, avoid discussing the business of medicine. Care that is good for our patients will be good for our practice. The EMR that most drives our quality efforts is the health maintenance table. It is used by all. The far left column of this table lists items that apply to this patient based on age, gender, disease, and medications. Those that light up red are overdue. The table also tells us when each item is due, as well as when it has been done in the past. We expect our staff to act on health maintenance items at every encounter. All overdue items on health maintenance are standing orders for all employees. On to the ABCs of heart health. This graph is the format in which we receive our data from PPRNet. As of February 2018, we receive graphs from 70 different performance measures on a monthly basis. We make them available on our practice's website, plymouthfamily.com, for all to see. The horizontal axis represents the past 24 months. The vertical axis is the percentage of our patients with an ischemic vascular disease diagnosis on their problem list who have a current antiplatelet prescription on their med list. For this measure, we are at 89%. As for aspirin, when a patient has an ischemic vascular disease on their active problem list, aspirin will light up on the health maintenance table. Every contact we have with that patient is an opportunity to review if and why the light remains red. With every patient encounter, the medical assistants update the current medication list, specifically asking about aspirin. If the medical assistant finds a discrepancy, they message the physician. This graph represents blood pressure control. The horizontal marks the past 2 years. The vertical depicts the percentage of patients who have the diagnosis of hypertension, whose blood pressure is less than 140/90. Since 2015, we consistently achieved 85% performance on this measure and are trying to push it over 90. Our routine in treating blood pressure is to see all patients at least every 6 months and obtain some measure of their blood pressure every 3 months. These are either numbers called in from home or measurements obtained from our office. We only refill medications if the numbers are at goal. Patients accuse us of holding them hostage to their blood pressure numbers. Metaphorically, we live and die by these numbers. However, in reality, our patients will also. Therefore, we never reflexively renew medications that are not achieving the goal. Our receptionists also won't let a hypertensive patient out of the building without scheduling a follow-up visit. Hypertensive patients periodically present with elevated numbers. Every elevated blood pressure needs an explanation and a strategy for improvement. Whatever the planned intervention is, it needs follow-up measurements. We strongly encourage home blood pressure monitoring, and for the past 33 years of our practice, we have offered free walk-in blood pressure measurement in what our patients have now dubbed our BP lounge. In order to obtain true resting blood pressure readings on walk-in patients, we appropriated a room adjacent to our waiting room. Our receptionist asks the patient to expose her upper arm and sit quietly. When the 5-minute timer goes off at the front desk, a medical assistant is called to take the blood pressure, recorded in the EMR, and agree on a plan with the patient. Many patients would object to the extra costs of visits, but will agree to visit our BP lounge. This graph presents our compliance with the 2013 ACC-AHA lipid guideline. On the horizontal is the past 2 years, and the vertical is that percentage of patients age 40 to 75 compliant with the guideline. Since mid-2015, we've increased from 42 to 57% performance. In applying this guideline, having the ASCVD risk estimator embedded in our EMR and readily accessible during the point of care has been essential. This estimator is available online at the American College of Cardiology website. Since 2015, we achieved 95% or greater performance in smoking assessment and counseling. Often, I forget who my smokers are. Since tobacco use plays into almost every problem a smoker presents with, I have it bold into every progress note. It reminds me to incorporate smoking cessation into every visit. I routinely run the ASCVD risk estimator and calculate every smoker's need for a statin. I then run it a second time with the tobacco switch turned off. Often the risk is cut by 50% and the need for a statin disappears. Another invaluable tool in improving our performance is PPRNet's patient-level report summary. For each of the 70 quality measures, this chart lists the number of patients eligible for that measure, the percentage of patients meeting the criteria, and the number of patients not meeting the criteria. On this slide, the blood pressure measure is highlighted in red. 717 patients are eligible for this measurement, and 57 are not at goal. If I want to find out exactly who those 57 patients are, I click on that line, and here they are. At our noon meetings, we often print off these lists, divide them up amongst the 11 of us, and retreat to our individual workstations. We then both plan outreach to that patient as well as try to understand why our system failed in delivering this item of care. We are proud to be one of the 2017 hypertension control champions. The lessons we have learned include the following: have the confidence to make quality paramount. Cultivate in every employee their ability to apply the science of medicine. Concurrently measure your performance in as many items as you can. Participate in initiatives like Million Hearts, and join a practice-based research network such as PPRNet. Quality performance in a small practice is very feasible if you use today's tools. Thank you. I would like to introduce the next presenter, Dr. Kathy Tong.
Thank you. I would like to talk today about the important role of cardiac rehabilitation as a secondary prevention measure to prevent second heart attacks. We know that patients who have had a myocardial infarction or a heart attack are at multifold higher risk for having another cardiac event compared to people who have never had an event. Cardiac rehabilitation is a program that helps patients recover from heart attacks and reduces their risk for second events. CMS reimburses for cardiac rehabilitation in this population. There are proven beneficial outcomes of participation as seen in this whisker plot from a meta-analysis of 34 randomized controlled trials with cardiac rehabilitation as the intervention. When we look specifically at reinfarction risk or second heart attack, patients who have survived myocardial infarction and were exposed to cardiac rehab had a lower risk of having a second heart attack compared to MI survivors who did not participate in cardiac rehabilitation. To illustrate how cardiac rehabilitation helps patients, here are two case studies of patients who are typical of those I see in our rehab program at UC Davis. The first is a 42-year-old woman who presented with a myocardial infarction and was ultimately treated with surgical coronary artery bypass grafting. This diagnosis was a surprise to her because she had none of the traditional risk factors associated with coronary artery disease. The second patient presented with escalating chest pain that was evaluated with a stress test. This suggested clinically significant coronary disease and was confirmed on coronary angiography. During the same procedure, he was treated with a coronary stent. He had every traditional risk factor for coronary artery disease. What the two of them have in common is that they are both young, they were both working full-time jobs at the time of their illness, they both have families with whom they would like to spend many more years, and they have common concerns after their events and before starting our cardiac rehab program. These are the common concerns that these two patients and others might have. Many of our patients have very specific goals, such as learning how to exercise independently, returning to work safely, eating healthier, and feeling well enough to travel. We have goals for our patients as well. We'd like for them to learn about cardiovascular risk factors, about their medications, and symptom recognition. Risk factor management is a critical goal for patients and providers. Patients who have never been on prescription medications in the past find that the adjustment from being healthy to having a chronic condition can be very difficult, and cardiac rehab eases that transition. Our program is a holistic clinical program that addresses many of these concerns. The core of the program is structured exercise. Patients can attend up to 36 monitored exercise sessions. Here's one of our patients. She's exercising in our rehabilitation gym. She's wearing a heart monitor and has a variety of exercise machines to use during a session. It's important, though, to recognize that cardiac rehab is not just an exercise program. We have a multidisciplinary team that also focuses on patient education, nutritional education, behavioral counseling, and tobacco cessation. We have separate adjunctive classes in our program for cardiac yoga and stress management as well. When patients have completed cardiac rehab, we do transition counseling so that they can sustain the healthy behaviors they started while in our program. Here are two of our nurses and our exercise physiologist. When they do the initial intake evaluation on a patient, they also assess the state of other comorbidities and design a care plan that addresses the core components needed to treat these non-cardiac conditions. On a typical day in rehab, a patient who is a diabetic and a former smoker may arrive. He will have a blood glucose check prior to exercise, then attach a heart monitor. While he is exercising, he will listen to a structured presentation from our dietitian about plant-based protein sources. And after exercise, he will join the other patients in the gym for a group stretch, followed by a meditation exercise. Before he leaves, the staff will remind him of environmental factors such as air quality that may affect his health. They will let him know that tomorrow is a spare the air day and that he should exercise inside. I'm very proud of the work done in cardiac rehabilitation. UC Davis is one of 162 cardiac rehab programs in the state of California. Despite the availability of programs, I know that cardiac rehab is still underutilized. Preliminary analyses of CDC and CMS data from 2013 illustrates this point. Approximately 450,000 Medicare fee-for-service beneficiaries at all ages had a qualifying condition in 2013 that would make them eligible for cardiac rehabilitation. This includes symptomatic coronary artery disease, myocardial infarction, heart valve replacement, and heart transplant. Of the beneficiaries, only 20%, or 90,000 individuals, used cardiac rehabilitation at least once within 12 months of their qualifying condition. Let's take a closer look at those 90,000 patients. Medicare will reimburse for 36 sessions within 18 weeks. We know that in cardiac rehabilitation, the dose matters. That is, patients who complete more than 25 sessions derive the most benefit. Of all the patients who attended cardiac rehab at least once, 19% of the patients attended 1 to 11 sessions, 23% attended 12 to 24 sessions, and 57%, or 51,000 roughly, went on to complete at least 25 sessions. A small percentage of those overachieved and went to over 36 sessions. However, potentially 400,000 of the eligible CMS patients are not gaining the full benefit of cardiac rehab. The topic of increasing patient participation is frequently discussed in the cardiac rehab world. Automatic referrals integrated into the electronic medical record for covered diagnoses is a good systems-based way to ensure that no patient is missed. Our program actively screens patients who may be eligible and contacts the provider for a referral if the criteria are met. We've had great success in working with the Cardiothoracic Surgery Service, and they have a 100% referral rate after bypass and valve surgery. They have also made this a quality metric for themselves, and they monitor it regularly. After the patients are referred, we have found that our retention rate has increased with a structured orientation. Many patients are unfamiliar with cardiac rehab, and the orientation has helped them learn what to expect and how they can benefit. If patients cancel an exercise session or fail to show up, we do follow-up phone calls with them to assess barriers, and we try to offer solutions. There are limited studies that systematically look at this very important issue of non-adherence to cardiac rehabilitation. Anecdotally, these are some of the reasons we hear for why patients have stopped coming. These can be roughly grouped into financial reasons, transportation-related reasons, motivational reasons, and there's overlap between the three. Some patients cannot afford to be away from work, especially those who are self-employed. For those with private insurance, the copay per session can be high and adds up over 36 sessions. Transportation and distance from their home to our cardiac rehab center is commonly cited as the reason for non-attendance. We are not unique in that our primary care network extends more than 40 miles from our main hospital, and driving to Sacramento 3 times a week can certainly be a burden. Certain patients also struggle with our goals to facilitate behavioral change and often stop coming if they feel that their way of life is being threatened or being criticized, as in our patient who told us that we were trying to make him a vegan. The solutions may become more clear if we study and understand the problem better. Some solutions can occur at a center level, such as through philanthropy. Many cardiac rehab centers have a copay assistance fund for patients who have a high copay. However, we need to raise awareness at the administrative level and above so that rehab may be viewed as separate than an office visit and not treated as such with copays. With respect to barriers related to distance and work time conflicts, there's a tremendous opportunity for growth here. Out-of-center cardiac rehab is a much discussed but little implemented strategy to help our patients. The available technology in telehealth and activity monitors dovetails nicely with the development of home-based rehab. However, lack of reimbursement for the work of monitoring patients is one of the main reasons this approach has not become more widespread. For patients with motivational issues, we need to diagnose and treat existing mood disorders such as depression that could be contributing to non-attendance, and we need to enlist the help of other treating physicians, such as the primary care doctor and the cardiologist who referred the patient. Letting the patient know you haven't forgot about them helps in some cases. Approaching the patient from a place of compassion and concern is critical in these conversations. Data supports participation in cardiac rehabilitation. Patients who participate in the program have fewer second heart attacks, as I showed you earlier, improved survival, increased physical function, and fewer hospitalizations. Once we have a patient enrolled in cardiac rehabilitation and they are participating regularly, the patient will have the maximum benefit. So back to our patients. The first, the 42-year-old woman who had a heart attack and bypass surgery, has currently completed 18 sessions and she is scheduled for more. She is back to work part-time and reports having more confidence about dietary choices. She's walking 60 minutes a day on her non-rehab days and she's still coming to the gym 2 to 3 days a week. Our 44-year-old gentleman who had angina and a coronary stent just finished the program. He has quit smoking but tells me it was very hard and he appreciated the support from our team. He too has improved exercise tolerance. He's gone back to work and he plans to continue his exercise at a private gym. The results are very typical of the patients who complete our program. We hope they will continue to live healthy and active lives. Thank you so much. And now I'd like to invite Dr. Wright back to the podium.
Wow. Thank you. This slide brings us back. Some people might call this a burden slide. Million Hearts and Million Hearts Partners call this the opportunity slide. So when you see what fantastic opportunities there are through public health and community-based and individual and healthcare actions, and especially because, again, hearing from our experts today and knowing what you all in the room and online know, we all know what works. And so it is now about implementing what works across the country, everywhere, for everyone. And again, I thank our speakers today for helping us see that. These are some tools and resources that are available. Our team has either developed these, again, under the guidance and leadership of Hillary Wall and others, or we have scarfed up these resources and shared them with permission from other people. I want to let you all know that today the 2018 Hypertension Control Champions Program launches. The door is open now for self-nominations and will remain open until the 6th of April. Please share this information with your network so that we can highlight later this year a whole new crop of very high performers, or positive deviants as we like to call them. I think this opens up our question and answer period. And first I'd ask Susan Laird. Susan, do we have anything online?
Thank you, Janet. We do. First, I want to let all of our online audience know you can submit your questions to grandraounds@cdc.gov, or if you're on Facebook Live, go ahead and post now. Our first question from Christine wants to know if other states are working on similar transportation initiatives based on the Tennessee model, and is Tennessee helping other states implement the same thing in their environments?
And Leslie, let me ask you to use your microphone. You have yours on? Good.
Yes, there are definitely other states that are looking at the intersection of transportation and health. And I think by and large, most sectors, planning and economic development, certainly parks and recreation, folks are understanding that health needs to be part of their decision making, and they're just in the process of figuring out how. So there are other states doing this, and we do talk to a lot of other states that are looking to try to innovate, particularly using existing public health resources and marrying those with resources from other sectors.
And if you do have a question in the room, if you would go to microphone on either side, or those of you who are in the front, just make sure that you hit your mic button first. Susan?
We have others coming in while we wait for people in the room. There was a reference in the presentation to avoiding exposure to air pollutants. Can you make some suggestions how?
Thank you for the question. I think that one of the biggest interventions you can do is just to have awareness. So in our region, we have a website that gives the air quality index every day, and it's easily accessible in a very user-friendly fashion, because ultimately the reduction of air quality is occurring, or improvement in air quality is occurring at a level much bigger than at the cardiologist like me, but making patients aware of how it can affect their heart health is definitely a part of our education process, and showing them how they can access this easy to obtain information on if it's a good day to exercise outside or not is sort of the role that we play. At a larger level, I think there are many other public health policies that need to happen to reduce the contaminants in the air, or the burden in the air.
And Leslie, would you like to speak to that?
Sure. From a transportation planning perspective, particularly in air quality, in areas that are in air quality non-attainment, that's one of the things that we're charged to do, is make sure that we're not putting more cars on the road and increasing those air pollutant levels. One of the things that we can do is, because they're predictive models, we can, the day before an air quality alert day, we can let folks know, and we encourage people to either telework or use public transportation, or think about a different way to get around. And in some cases, that has helped us actually avoid hitting the levels that we feel like we'll be seeing on the air quality alert day. But yes, systemically, we're looking at how can we reduce the total number of mobile air pollutants on the roadways so that we don't have to have those warnings for not exercising outside.
And I might just add that there are materials available on our website about small particle pollution. And then Dr. Shuckett?
Yeah, thanks to all the speakers for terrific presentations. And Dr. Strader, I want to congratulate you again for being a champion. I was intrigued that you talked about your journey began with 20 years ago with the electronic medical record. And as you've incorporated changes in guidelines and really strived for incredible quality, I wondered if you could comment on how easy it's been to keep the electronic medical record up to date, or whether you kind of have it fixed and you're really doing the quality effort independent of that now.
We did it in the context of a larger organization, and I can't emphasize that enough. Where we would get together multiple practices across the country and give each other, specific talks on how to manipulate the EMR to accomplish these goals. We did multiple studies, and at the beginning of the study, we know they're going to be looking for data like, blood pressure control and lipids, and then we have to know how to enter that data into our EMR, so our organization is going to be able to extract it out of our work. And so every study was a preparation on make sure we're coding things right, so it's extractable, and then the process never stopped. As I said, we continue to get these slides 15, 20 years after the studies have been completed, and And our EMR is very malleable. I mean, it's individualizable. It's clinically oriented, not a business oriented, not a billing model EMR. So it was designed from the beginning to work in a clinical setting, and in a primary care setting.
Oh, there was a question at the back.
It partly answered my question already, but I was curious about the speaker's view of some of the more recent advances in publicly consumer available genetic testing. A lot of it is based on ancestry interest, but I've noted that a couple of these companies like 23andMe have a fairly extensive questionnaire that's not required to get your results, but it's probably 2 hours worth of survey questions on family health, history, behavior, and they're obviously collecting this data. But I'd be curious your perspective on the value of those sorts of things, understanding that the technology is fairly early, and whether or not that data might be available to healthcare companies in some sort of blinded fashion. But could that have value in terms of preventative mechanisms or education of patients or even physicians on how to handle some of these issues?
I feel as the transportation professional, I shouldn't be answering that question.
I wasn't looking for any specific answer. I was just curious from your professional perspective if there's value in that, and has that been part of any of the discussions that you've had in your practices?
Obviously, there's potential value there. I think, though, where we come from, there's so much science that doesn't get applied right now that's so well known. That our focus was on simply getting somebody to recognize the idea that a statin is a heart attack pill. And it doesn't have anything to do with their blood or their cholesterol numbers. If you'll take it, you'll receive the benefits. So there's so much science that's not applied that science, which is ahead of us a little bit, no doubt will have its day. But we're overburdened with so much stuff that is well supported, well evidence-based.
I mean, I think the concept of precision medicine is sort of what you're discussing, which is if we could find out not just the family history, but if we could find out each person's individual genotype and then figure out what the different variants are within their genetic code that might predispose them to being, say, aspirin responsive or less aspirin responsive. I think there's a lot of interest in trying to match up certain drugs and certain therapies to people who can be predicted to be responders based on their genetic code. I think it's an intriguing idea, and certainly there's a large amount of funding and research in this area. However, I have yet to see a widely implemented treatment plan based on this, because I think that we are starting to show a relationship between genotype and responsiveness, but we need to make that next leap to actual clinical outcomes. And I think when we start to see that, if you can show that we genotyped all these people and these people respond better to warfarin and these people don't, or aspirin or whatever drug we're looking at, and then we change their therapy based on that, and as a result the entire population had better outcomes, then that will be the next big leap forward. But for now, I think we're still in the early stages of that science.
Susan?
What is the impact of new lower blood pressure standards on hypertension control?
I think it'll raise the discussion. And people are concerned. Blood pressure is a well-accepted item yet. In my community, immunizations take it on the nose a lot, and we have to do a lot of fighting back of pseudoscience. The statin drugs also, there's just an overwhelming amount of negative information out there that we have to beat back. But blood pressure is still accepted, and even the chiropractors take people's blood pressure. And so people don't argue about that. So if we come to them with the idea that, there's science that says, you should be lower than what we thought in the past, I think they'll buy it.
I have a follow-on question from a different Susan from New Mexico. To what extent, if any, does Million Hearts plan to endorse and promote the 2017 ACC-AHA guideline to diagnose hypertension starting at the greater than or equal to 130/80?
I can take that one. So CDC and CMS don't officially endorse scientific guidelines, but I think we would say there are many things about this new hypertension guideline that we are excited about and that we look forward to. The overarching message is that hypertension remains a major problem in the country, a treatable problem, and one whose treatment through lifestyle and medications will end up preventing all manner of bad things happening to good people. John, thank you.
And always good to end on a positive note, looking forward to opportunities. Let's have another round of applause for our outstanding speakers. Please join us for next month's session of Public Health Grand Rounds. Thank you.